So this is my first time ever doing a online tutoring session, and I just think it's a little bit easier because I know a lot of people wanted to do like a one-on-one, but it's just kind of hard to get to meet with everybody. But also because I know a lot of people really like how I organize information and such, but I kind of don't feel comfortable like giving everyone my outlines just because uh, this is kind of illegal and I don't want to get kicked out because I got too much going on. Anyways, so that's why I decided to do this because this is great to provide a summary and to also give you the resources needed without me actually physically handing you something so that you can study along. So without further ado, let's get started with week one of mental health. So the first overall category or topic that we're going to be talking about is just the introduction to mental health. So I organize things differently across from ATI, the ATI book, to the PowerPoints and to any handouts, and I combine them all together to fill in any missing gaps. I also combine things, content from practice questions that we receive that weren't in the PowerPoints per se, and then also the key points as well. So everything's just kind of mashed together to have kind of a very thorough review across all spectrums so that we're not missing any key details just in case. So that being said, let's start with an introduction to mental health. So there are 4 topics to discuss in the introduction to mental health. So the first being is the origins of mental health. So let's think way back when and think about what people originally thought mental illness came from. And that was the germ theory. So individuals back then thought that there was a mania germ or a depression germ or something that was in the environment. But this was just proven because, when the microscope was invented and everything, they were unable to obviously locate a mania germ or a depression germ. And that led to the next one, which is the discovery of medicine, which helped fix neurotransmitters, insufficiencies, or what have you. So that led to that current theory of the neurotransmitter imbalance. We also have what's called the diathesis stress model. And the diathesis stress model just basically tells us, the risks that may be involved for someone to have a mental illness. So breaking them up, the diathesis part just basically means that they're at risk because they may be genetically predispositioned to have some sort of mental illness. Now, while there is no genetic gene that's isolated, that's schizophrenia, we can relate this to kind of like diabetes, how diabetes is actually a genetic link as well, but there is no diabetes gene. It's just the risk of inheriting, some of the risk factors that are involved. Then the second component of the diathesis stress model is stress. So stress is stress. Stress is right now crying, and then bam, depression. Anyways, and then family, environment, all that kind of stuff can go to stress. The second category now, moving on, is characterization of a mentally healthy person. So it's important to know this because this actually sets the characteristics or the guidelines to have a mentally unhealthy person. So let's go over some of the things that we should know about in a mentally healthy person. That they're able to think rationally, that they have self-esteem, they're able to foster relationships, grow socially and psychosocially, cope with stress or be resilient, and be able to set goals. So essentially a mentally unhealthy person is the opposite. So that's pretty easy. So maladaptive coping or poor resilience. So meaning that maybe they're coping, but they're using cutting instead. That's called maladaptive coping. We also have social withdrawal and loss of goal orientation. So individuals who have loss of goal orientation would generally say like, I just don't feel the purpose of like moving forward anymore. And then losing the ability to think rationally. So that's all for that part. Moving on to the third topic within the introduction to mental illness is the Sigmund Freud's theory of personality. So here we have three components to Sigmund Freud's theory of personality. We have the id, we have the ego, and then we have the superego. So the id is essentially what is our primitive wants and desires. So essentially what occurs in the id is that we see food, we're just going to eat it because we're starving. And when we talk about a 2-year-old, they're very much controlled by their id. Because if they're hungry, they want something, they're going to start crying for it. Because they're unable to cope with, that situation or whatever decision that's presented to them that is unfavorable. So they're going to just start crying because, if they want milk, they're going to cry for that milk. Because they don't know anything else, right? So problem is if you have an overactive id. So, this is for anybody really. You have an overactive id, that means you may have very impulsive desires. You're just going to do it. So that kind of correlates a little bit to ADHD a little bit. They're very hyperactive. And then the other thing is criminal behaviors. If you have an impulsive id, you can actually have STEM, antisocial personality disorders. Because, criminals, they're just impulsive. They'll just go and bang. Such a bad thing to say. Anyways, then the ego is the second component. Ego is you are partially conscious and partially unconscious. And I'm sorry, id is completely unconscious. You're unaware because it's your wants and desires. Ego, you're partially unconscious and conscious because this is your decision maker. So example is that if a baby or you, not gonna judge, was presented with, like the example we spoke in class, a fruit roll-up versus broccoli, and the mother or whoever is offering it to you says, well, you need to eat your broccoli first before you eat your fruit roll-up. And then you'll be able to eat your fruit roll. Then your ego is going to be like, all right, now, do I eat this fine tape? Or do I eat the broccoli and then eat the fine tape? Because then everyone's going to be happy, right? So I'm going to eat the broccoli so that I can eat the fine rainbow tape at the end. So that's what your ego is going to be doing. This normally happens around age 3 to 4 where they're able to, think more better. Anyways, then superego, this is completely conscious. The reason why is because your superego tells you what you want to be. It's your ideal self. So you make decisions based on your ideal self. So example is that if you see Snickers versus seaweed, again, another example in class, your id is going to be telling you eat, just eat. So you're just gonna eat everything, right? Then your superego is gonna tell you, well, the seaweed has less calories and you a little fat. So maybe, did I say the seaweed? The Snicker. The Snicker or the seaweed? The Snicker has more calories and you a little fat. I don't remember what I said, but the Snicker has more calories and you a little fat, so you better eat that seaweed to obtain your ideal self, which is healthy weight. Versus the ego will tell you what to do. So that's basically saying, you know what? I'm going to fulfill my id and eat that Snickers bar because your boy is craving some sugar. Or it'll be like, you know what? I'm going to listen to my super ego because I want to be a skinny legend. So it's going to do that. After that category, we have our last one, the fourth in our introduction. It's the standardization of mental illness. So this is very simple. Essentially, we bring to discussion the DSM-5. So this is called the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition. So this just offers a criteria, a guideline, a standard for clinicians all across the nation, so that we're able to effectively diagnose and just speak the same language, from this state to the next state or whatever. So we're not misdiagnosing everybody, right? The problem is that mental illness is defined by culture, and culture is defined by the societal norm. So this is more pertaining to our Western culture because in the lectures that we spoke about, suicide, for example, here we view that as, depression is very a serious thing, but suicide is considered honorable in some locations. And so it's something to keep in mind. And the last thing that is a great segue to inpatient care is the factor of resilience. And so resilience is just basically not that you are unaffected by stress or unaffected by traumatic events or whatever have you. It's the ability to recognize stress, readily deal with them, and then learn from those experiences instead of falling victim to it. So everyone has resilience to a certain degree, and that degree can be enhanced with help and practice. And so that's why this is a great jumping off point for our next topic, which is inpatient care, because what we try to do for them or help them understand to reinforce that positive resilience is to be able to identify a problem, accept what can't be changed, and focus on what can be overcome. And with that being said, we're going to go on to our next topic. So let's review briefly before we go on origins of mental health. So what are our theories? We have the germ theory. So just think about that. I'm not going to re-answer it again, but germ theory. We have, a diathesis stress model, understanding the difference between diathesis versus stress. Then we have characterization of a mentally healthy person versus a mentally unhealthy person. Sigmund Freud's theory of personality, so differentiating between the id, the ego, and the superego. Understanding how we standardize mental illness using the DSM-5 and the importance of it, and what defines mental illness between cultures and cultures. And then also understanding what resilience is and what we can do to help promote positive resilience. Move on to our second topic of psychiatric care. So as I stated prior, resilience, we want to foster these types of things. So what is the criteria for them to be admitted and what types of services that we can provide? This is this next topic. Chapter, I guess, psychiatric care. So what we have to talk about are 6 overarching categories. So we have inpatient psychiatric care, inpatient therapy, inpatient nursing care, the mental status examination, patient rights in psychiatric care, and then kind of following up on that and elaborating a little bit more levels of restrictions. So those are 6 things that we're going to talk about when we talk about psychiatric care. So the first one, inpatient psychiatric care. I've been saying psychiatric care, blah, blah, blah. Psychiatric care, inpatient psychiatric care. There's 2 categories, voluntary and involuntary admission. So voluntary is voluntary. We get this. There's nothing to really talk about. They just kind of walk in because they identify that they are at a risk to themselves or etc. Involuntary admission is a 5150 hold. So there are 3 criteria to be able to be involuntary admitted on a 5150. Either you're an immediate danger to yourself, you're immediate danger to others, or you're gravely disabled so you're unable to care for themselves or care for yourselves. So what's the duration of a 5150 hold? It is 72 hours after it has been written by a provider. And that's all for the first category, inpatient psychiatric care. Now let's go a little bit deeper. They're in. What can we do to help them? We have inpatient therapy, our second category. So here we have cognitive behavioral therapy, pharmacological therapy, milieu therapy. And those are the big ones, okay? So cognitive behavioral therapy, just kind of splitting that up, cognitive section of cognitive behavioral therapy. It's just focusing on individual thoughts and behaviors to solve current problems. So you're basically changing attitudes towards life experiences. And this is great for helping with, anxiety, depression, or you're just kind of making yourself think more positively about something that happened. Versus behavioral, this is that behavior is learned and has consequences. So let me read this off for you. Abnormal behavior results from an attempt to avoid painful feelings. Therefore, we should, change maladaptive or abnormal behaviors. And that can occur without the need for insight for the underlying cause of the behavior. So basically, we are just making their behaviors a little bit more positive, not maladaptive. And so that's why those two go hand in hand, because we're changing mind and body. So that's very important to remember. Pharmacological therapy, again, this is our medication, and it's very important to get started on our drugs. Don't forget, there's a lot that's going to be on our proctored exam, so this is very nifty that we got in class. And then the last one is milieu therapy. Very important. Milieu is essentially all aspects of the environment. So we are providing, a comfortable space that is free of, excessive light or noises or distractions, and that's just basically to try to, calm them down, recenter them. And the main hallmark things to remember of milieu therapy, the main feature, okay, is safety and success. Safety and success. So you want to make sure that they are not harming themselves while they're in this milieu environments, and also that they are not going to be able to harm other people as well. And then why success? Because, we want them to be able to, again, return back to normal, not be so, so safety and success, okay? That concludes that. The next one is inpatient nursing care. So this is kind of like our interventions, if you want to think of it. So to remember, observation, level of observation has to equal the level of risk. So someone who is not as, high risk or whatever, generally, if you see in the facility, many of them, involuntary or voluntary, we do 15-minute rounds. So it'll be 15-minute rounds. Now, if they are a very severe risk, then we might want to do one-on-one. So those are the two levels of observations that we learned about. And so our role as a nurse in inpatient nursing is to provide mental status examinations, as well as obviously our physical health assessment, our medication management, our managing emergencies, and preparing for discharge. So technically everything exactly the same as far as this list goes, with the exception of handling of psychotic medications, as well as their mental status examination. So that concludes that category. Our fourth one, mental status examination. So elaborating on that, it's very important to remember our acronym, aseptic. So aseptic, breaking it down, appearance and behaviors. So that's the A. Speech, emotion, perception, thought process and content, insight and judgment, and then cognition. So that is breaking down the acronym. Let's go through each of them one by one. So when we talk about appearance and behaviors, essentially when you're doing the first section of the mental status examination, you are just looking at them. You're describing what they are wearing. Are they wearing bright lipstick, or, this beepy yellow shirt because we're bored? Or what types of behaviors that they're doing if they're, eccentric or whatever. Also, I just woke up, so I'm in my pajamas. So that's my appearance. They're in their pajamas, and they're looking a little disheveled, and he acted a little crazy. Anyway, so then speech, we want to remember rate, rhythm, volume, tone. So those go into speech. So how are they speaking? Loud or quiet, or angry or sad, or, slow. So that's rate, rhythm, volume, tone. Emotion. So emotion, we want to make sure that we understand the difference between mood versus affect. So mood is an inner representation of how they feel. So you don't know unless you ask. So you definitely want to say, how are you feeling today? And then their response can be, I am angry, or I am hopeless, or I feel down, etc. And then affect is an outer representation of how they feel. So essentially, you can look at them and it'll be like, that's affect. So it's how they show facial features. Now the problem is, if affect doesn't match mood, or mood doesn't match affects or whatever, then there may be some underlying things to consider. The next part is perception. So perception's composed of either hallucinations or illusions. So hallucinations are essentially the five senses. You're tasting something that's not there, you're seeing something that's not there, you're hearing something that's not there. That's what a hallucination is. So it's a false sensory experience. Versus illusions, they actually are able to hear the same things that you hear, but they perceive it differently. So I can hear a fan and it sounds like a fan. Versus other people who have these false illusions, they'll hear the fan and they'll think it's an airplane or a helicopter. And they'll just be like, oh, that's an airplane, that's a helicopter, when it's not. Next is thought process / content. So thought process is essentially, you can ask them to talk about their experiences, or tell a story. And is what they are saying making sense? Because is it linear? Is it disorganized? That's thought process. And then content is essentially content. So what are they talking about? They're talking about their mom or their dad, or nursing school, or what have you. The next one is insight and judgment. So kind of similar. Insight is basically, are they understanding what is going on? Versus judgment, is it poor or good? So you can offer them kind of like a situation. For example, that was given to me in class was, what would you do if your couch was on fire? And someone who has good judgment would be like, I would call 911 and I would get out the house. And other people would be like, oh, I'd probably take a bath, or I'd, lock the door. It's like, that's poor judgment. The next one, last one actually of the MSE, is cognition. So very important to know, just like how each one had their, their own components, hallucination, illusions, and all that kind of stuff. Cognition is multifaceted and has 3 components. So important to remember this when you're assessing cognition. You're not leaving any of these out. So memory, ability to think abstractly, and multi-step processes. So when we talk about memory, it can be remote, or it can be short-term. So when we talk about remote or short-term memory, remote is basically saying, oh, can you tell me about, your childhood, right? That's like very far back, right? Versus short-term is, I'm going to tell you 5 numbers and can you repeat them back to me? Ability to think abstractly is essentially, the 2 birds with 1 stone. Are they able to comprehend that means that you're knocking 2 things out at once? You're able to multitask, or they're just going to be like, oh, that means you have a really good arm. Like, that's not right? That's not you're not thinking abstractly. And then multi-step processes. This is essentially giving them a piece of paper and folding it in half 4 times. But that's not the only example. Again, it's anything that requires multiple steps. And sometimes if they don't have this ability, they'll just look confused and they won't know how to proceed. So that's the MSC. Our 5th topic within, psychiatric care are patient rights. So it's very important to also understand as nurses the legality of psychiatric care. Now, basic rights are still in effect even within a 5150. So they still have, and this is very important to remember, right to treatment, right to refuse medication or treatment, right to an informed consent, least restrictive measures, right to confidentiality, right to even use a telephone, right to even see visitors. Now, the only right that is withheld within a 5150 is the right to leave. And again, a 5150 lasts for 72 hours, so they cannot have the right to leave for the first 72 hours. Now, there are some specific exceptions and considerations that we definitely need to understand. And the first being the exception to the right of confidentiality. So say the client was admitted due to a danger to others, or they were threatening to kill someone. So we have a duty to warn others and that individual because obviously, right? The other one is abuse because we're mandated reporters. The third one is under oath in front of a judge. I don't know why I'm doing the Hunger Games like. And the other one is those immediately involved in care, obviously. So you don't want to be like the CNA taking care. You don't want to be like, I can't tell you nothing. And then they get like beat up or something, So it's very important. Now, an example to point out is a past therapist still cannot get information. So you can neither confirm nor deny. It's those immediately right now concerned with their care, okay? So don't be tricked by that. The next exception is the exception to the right to refuse treatment or medications. Now, the thing is, you can only revoke for emergency intervention or acute risk of injury. So I know it's like a double negative, but essentially, if they are imminent, it's like very, very severe and urgent, okay, and they're still refusing medication, we can override it, okay, but we definitely need the documentation for it because we are invading a right. But if it's again acute emergency, we can take that away, okay, because they can file a tort. So very important to remember. The other one is the condition for seclusion and restraints, okay, so we cannot use restraints or seclusion just willy-nilly, okay? And it's important to understand that we have to do things in a least invasive to most invasive pathwise procedure. So when can we use? Only when an imminent danger and other alternatives have been exhausted, and for the shortest time only. When not to use? For convenience or for punishment. We cannot do that. So when they are on seclusion or on restraints, we need to monitor physical and psychological needs. We have to tend to them. So, making sure that we're observing them, monitoring their when they're restrained, it's very important, okay? And then the last topic to talk about when we talk about patient rights in psychiatric care is the revocation of rights by the nurse. So we can, despite them having everything, again, we can revoke if it is imminent danger or some high acuity or risk, only if we have safe reason to. The exception to that is we cannot revoke the right to receive medication. That's different. We can't do that. But, for example, the right to write. So what do I mean by that? If they have suicidal ideations, with pens or pencils, we have to be smart about it. So we could alternatively take away the right to use pens or pencils, but we'll give them crayon. You see how that goes? So we can negate a right to refuse if it's an acute risk of injury, and we can also negate a right if, they are abusing it in any harmful way or something, We definitely need to have the documentation to back that up, though, okay? And then our last thing in psychiatric care is levels of restriction. So that's a good segue point because we definitely want to employ everything before we go to restraints or something. So it's in this order, top to bottom. So verbal/nonverbal, milieu, chemical, seclusion, then mechanical constraints. So let's talk about each one of those individually. When we talk about verbal and nonverbal, again, therapeutic communication, I don't need to go over that, and nonverbal, solar, okay? Milieu, again, the environment, reducing any stimulation, light, sounds, distraction, harm. Generally, that's pretty Gucci because then, they're able to calm down. Chemical, medication. So this one needs an order. Seclusion, you kind of put them in their own private room. So the patient does not have the right to their own private room. That's actually seclusion. So, this also requires an order as well. The last one is mechanical restraints. And this one, you have to make sure that you did all prior interventions first. So you need short-term, never PRN, and you need to monitor the patient while they're on restraints because you want to take them off as soon as you can. So the importance of understanding this pyramid of sorts is that after you go down, your priority is try to get them back up, okay? And with that being said, that concludes that section of psychiatric care. Let's review what we just learned about in that last section of psychiatric care. So let's talk about inpatient psychiatric care. What are some of the inpatient psychiatric cares that we can provide someone? Well, we have voluntary and involuntary admission. So involuntary admission is a 5150 hold. Remember the 3 criteria for admission and remember the duration for it. Inpatient therapy, we talked about cognitive behavioral therapy and the 2 components of that. pharmacological therapy, and milieu therapy. And what are the hallmarks of milieu therapy? It is safety and success. In inpatient nursing care, we talked about the level of risk has to equal the level of observation and the roundings that we would normally do, Q15 or 1-to-1. And what are our roles as a nurse within a psychiatric unit? Well, performing mental status examinations, physical assessments, medication, all that type of stuff. And then breaking down the mental status examination, we talked about aseptic. Remember the components of that? Appearance and behaviors, speech, rate, rhythm, tone, volume, emotion, mood versus affect, perception, hallucinations versus illusions, thought process, the difference between thought process and content, insight and judgment, and then cognition, understanding that there are 3 components of that, memory, ability to think abstractly, and multi-step processes. Then we talked about our patient rights in psychiatric care, even if they are on a 5150. So the right to treatment, the right to refuse treatment or medication, informed consent, least restrictive doctrine, right to confidentiality, telephone, visitors, writing, all that kind of stuff. And the only right that we withhold on a 5150 is the right to leave the first 72 hours. Now, remembering the exceptions and also conditions to some of these rights and nursing interventions, we have the right exception to the right to confidentiality. There are 4 things that are the exception. A danger to others, we have the duty to warn. Abuse, mandated reporters, duty as mandated reporters. Under oath in front of a judge and those immediately involved in care. The exception to the right to refuse medication, so we can revoke this if it is an imminent or emergent danger or acute risk for injury. But you have to make sure you document because they can file a tort. Condition for seclusion restraints, remember, shortest term possible. Make sure you exhaust all your alternative therapies and also making sure that you are observing them and that it is not for convenience or for punishment. And then the revocation of rights by the nurse, only if you have safe reason to do so. However, you cannot revoke the right to receive medication. The last one that we talked about is the levels of restriction. Remember, we're applying it from a top to bottom manner. We have verbal/nonverbal, milieu, chemical, seclusion, mechanical restraints. And understanding that the last 3 require an order, and your role is to make sure that they're able to go back up if they were to go down. We can talk about our next chapter or overarching theme is the continuation of psychiatric care. So what does that mean? Well, when a 5150 ends, which is after the 72-hour ends, 3 things can occur. So either they are discharged, hooray, we're good, or they have a voluntary continuation of treatment, or the facility requests to place them on a 5250. So that's what we're going to be talking about. So let's talk about how many things do we have involved here? We have 1, 2, 3. So we have 3 things within this topic of continuation of psychiatric care. We have the 5250 specifics. We have 5250 hearings, and then other levels of psychiatric care. So, we're going to talk about like community and support groups and stuff like that in the last one. So hopefully that provides a roadmap. So let's talk about 5250 specifics. So why would we ever, place someone on 5250? Well, if we feel like they're not getting better, we can order a 5250. So if they're not taking their medications, but we think they need it, they can also go to the mental health court. Now, this lasts for 14 days. So the other one's 7, this one's 14. It extends it by 2 weeks. And both, the importance is that not only the 5150, but also the 5250 allow the hospital to monitor and observe against will. So that's very important to understand, okay? But the exception to this is that only in a 5250 is the patient actually able to attend these like 5250 hearings. And that is our next category, the 5250 hearings. So there are 3 components. We have the writ of habeas corpus, the Reese hearing / medication capacity hearing, and the temporary conservatorship hearing, or the 5350, which we'll talk about last. So as I said prior, the writ of habeas corpus is a legal request to release from the facility that the patient him or herself can file themselves with the help of an attorney, advocate, or facility staff member. You're basically pleading your case to leave in front of the judge. Now, the REIS hearing or medication capacity hearing is what the facility can file, and this basically says that the client is mandated to take medications prescribed by the provider through IM or PO unless the judge favors the client in the REIS hearing. So this is important to remember because the facility can only file this because the 5150 does not allow you to revoke the right to refuse. Okay? Technically, we talked about that. But only in a REIS hearing in a 5250 can you just force it upon them. Okay? Temporary conservatorship hearing. This is a 5350, and so this is essentially extension of 30 days. And basically, what all you're doing is that you are having someone being appointed or organization to care for an adult who cannot care for themselves. So this is if a patient is not better, even if they were following with treatment. So we don't really talk about 5350 that often, but that is that. And the last thing to talk about in this topic is other levels of psychiatric care. So very important to remember, we have what's called a partial hospitalization program. So this is like short-term treatment for clients who are well enough to be able to go home by the end of the night. So this is great. But they have to have a responsible person and a safe environment at home. That is one of the conditions to be able to go to a partial hospitalization program. The next one is the ACT, or the Assertive Community Treatment Program. So basically, this is in cases of severe mental illnesses and they are non-compliant with traditional treatment. So I'll read this off. The importance is it reduces reoccurrences of hospitalization, and it provides crisis interventions, assistances with independent living, and information regarding resources. Obviously, we have outpatient programs. We want to advise follow-ups with the psychiatrist and the doctor frequently and regularly. And then we also have what's called community treatment centers, where they will help provide educational groups, medication dispensing programs, and individual and family counseling programs. So we have some examples: Alcoholics Anonymous, anger management programs, and support groups. So that's very important to remember for that. View the continuation of psychiatric care. So here we talked about what happens when the 5150 or the first 72 hours ends. Well, three things can occur: either psychiatric discharge, voluntary continuation of care, or an order for 5250. So 5250 specifics, why? Why would we need a 5250? Well, we feel like they're not getting better, then we can get an order for 5250. So this lasts for 14 days, and the importance is that it illegally allows a hospital to monitor and observe against will again. The importance of a 5250 is that this actually allows for hearings. So the 5250 hearings are the writ of habeas corpus, REIS hearings / medication capacity hearings, and also temporary conservatorship hearings, or the 5350. So the writ of habeas corpus is something that the client can actually file themselves, and this is just a legal request with support of an advocate or a lawyer or maybe a facility staff member to basically plead in front of a judge that they're okay and they can leave. A REIS hearing is what we can file, and again, this is when this basically says that the client is mandated to take the prescriptions provided by the provider, IM or PO, unless the judge favors the client. So this allows us to revoke the right to refuse, like actually, okay? Then the last one is the temporary conservatorship hearing, which is the 5350. And essentially, this is the appointment of someone to basically hold them responsible to a client who cannot care for themselves. And this normally happens when a patient is still not better even after treatment has already been sought and already fulfilled. And this extends to 30 days. The last one is other levels of psychiatric care. We talked about the partial hospitalization programs, the pros of it, especially that they're able to go back to home. But the problem is that they need to have a safe environment and they need to have support and a responsible person. ACT is Assertive Community Treatment Program, and essentially this is basically when they're severely mentally ill and they're non-compliant with traditional treatment. And then obviously we want to advise that they are following up with their psychiatrists and doctors regularly. And also we also have community treatment centers such as Alcoholics Anonymous, anger management programs, and support groups, because community treatment programs or centers provide educational groups, medication dispensing programs, or individual and family counseling. Next chapter or broad concept topic is therapeutic relationships. And here we're going to be talking about 6 concepts, the first being concepts of the nurse-patient relationship. Then we have Peplau's model of the nurse-patient relationship. We have the phases of treatment, factors that help the nurse-patient relationship, factors that promote patient growth, and the importance of the treatment team. So when we talk about concepts of the nurse-patient relationship, just a brief introduction, this is the basis of all psychiatric nursing. And to establish that, the nurse has to be safe, confidential, reliable, consistent, and set clear boundaries. And that is what's going to cascade us onto our little sub-bullet point under the concept of the nurse-patient relationship is therapeutic relationships versus social relationships. So it's very important to understand the difference, because a therapeutic relationship is as follows. It facilitates communication of distressing thoughts and feelings. It assists patients with problem solving, helps patients examine self-defeating behaviors and test alternatives, and promote positive behavioral changes. And that's good, because social relationship is one that's just for friendship. It's fulfilling the needs of the patient and the nurse. Now, that's what we do not want. The needs of the patient are always first. We do not fulfill our needs. So let me read these guidelines for a social relationship. Initiated for the purpose of friendship, socialization, enjoyment, or accomplishment of a task. This is where mutual needs are met and content of communication is superficial. Now, communication in a therapeutic relationship is beneficial, supposed to be beneficial for the patient, not for us. We are not there to have like a friendship with them. We're there to have a professional relationship, to be able to promote behavioral changes, allow them to communicate to us about any problems or concerns, so that we can work on positively, coping or reinforcing behavioral, positive behavioral stuff. And so how can we do that if we have a social relationship where everything is very superficial and we're putting our needs before theirs? That's not how it works. So blurring of the boundary occurs when the relationship slips into a social context and the nurse's needs are met at the expense of the patient. So that's something we want to be aware of. Now, something else that we want to be aware of in the nurse-patient relationship may be transference versus counter-transference. So transference is basically kind of like imprinting of the patient's past memories or experiences onto the nurse. So this can be bad, and we definitely have to recognize that, because an individual who has transference may treat the nurse a different way. Now, this may seem good or bad, depending on the circumstance, but regardless, it is bad for the patient's overall quality of care, because say they are treating us very nicely, but not any other nurses, because they had a friend or a family member or another nurse in the past looks exactly like us, and so they favor us. But then when it comes to other nurses, they don't want to do anything with them. So that's very bad. Likewise, if they had a bad experience with another nurse or someone else that looks familiar to us, they won't work with us at all. That's transference. And countertransference is exactly the opposite. Say we have a person that looks like our family member. Well, we want to try to treat them more than other people, right? And so that's countertransference, and that can actually lead to poor justice, which is one of our ethical principles that we're going to be talking near the end as we summarize and wrap up this entire lecture. So the second topic is Peplau's model of the nurse-patient relationship. Here she describes the orientation phase, the working phase, and the termination phase. So in the orientation phase, you're introducing yourself, you're establishing rapport, and you're setting those boundaries early. Okay, you're establishing the goals of termination that have to be met to be in order to be terminated, and you're also establishing confidentiality within the patient as well. Within the working phase, again, this is very simple. All you are doing is gathering data, you're assessing, and you're promoting the patient's self-esteem, problem-solving skills, and the use of language to communicate any discrepancies or any problems that arise so that you can work with them. You can work with them to adjust their behaviors to attain those goals in the termination phase. As I said prior, promoting practice and expression of alternative adaptive behaviors, evaluating problems and those goals. Then hopefully, if everything in the working phase is met, we can move on to the termination phase, where essentially we are just calling it off. We're setting it in stone that yes, this is it. This is the termination phase, so that they have clear expectations. They know what they need to focus on. So you're reevaluating goals and you are summarizing the objectives achieved. You're reflecting on the progress and you're reviewing the situations that have occurred so that they can incorporate those positive coping scenarios or strategies into their lifestyles now. Next is the phases of treatment. This was a handout. This is just a really easy summary of everything that we kind of talked about here, and they put it into groupings. So we talked about the prodromal stage, risk factors that lead to inpatient stay, acute care, continuation/working phase, and the maintenance phase. So it's just kind of like a line, a pathway, the phases of treatment. So prodromal phase is essentially a patient is kind of showing premonition that they might have a mental illness. For example, social withdrawal is a good one, or maybe they're feeling lethargic. Then you have the risk factors that are involved that may lead them to have inpatient stay. For example, the diathesis and stress model that we talked about, either they're pre-programmed in their genetics or something happens and they snap, which leads to the acute phase or the acute care phase. Remember, we talked about the three requirements for inpatient stay: harm to others, harm to self, or gravely disabled. Then we have the continuation or working phase. So now they're here with us. What can we do to help them? Again, that was the same working phase that we talked in Peplau. What are we doing here? We're doing our MSC, we're doing our patient rights, we're trying to stabilize and return them back to baseline. That is our goal. And how do we do that? Well, working on positive coping mechanisms, and if things aren't working the way that they are, maybe we have to employ those measures that we talked about. Remember, we talked about verbal and non-verbal communication, therapeutic communication, milieu therapy, maybe even having to go to chemical or physical restraints or seclusion. So those are all part of the working phase. And lastly, the maintenance phase, the hallmark of this is to prevent relapse. And how do we do that? We part of the termination phase is that we talk about things that they learn, things that they can incorporate into their life, and maybe contacting case management or social workers to connect them to continuity of care, like we talked about outpatient services, and we talked about community outreach programs and support groups. That's what's going to be in the maintenance phase. The next category is factors that help the nurse-patient relationship. Again, very simple. I'm just going to kind of read them off. Consistency, listening, initial impressions, promoting the patient's comfort, and some things that promote the patient's growth is trust, active participate. I'm going to the next one. Oh, my pencil just flew off. It said I am not participating. So factors that promote patient growth would be the trust, active participation, genuineness that they want to change. Things that you can do as well is provide empathy for them, but not sympathy. And basically that's it, helping patients develop the resources that they need to just live positive, non-maladaptive lifestyles. And the last thing I want to talk about is just the importance of the treatment team. And this one's, pretty easy, obviously. Just going over the MD and the NP does the orders and the diagnosis. That's basically it. Honestly, I don't know what the doctors really do. I feel like we're on the floor most of the time. Then the RNs, they're doing a lot of things. Mental status examinations, medication education groups, patient teaching, continuity of care, supervising, all that kind of stuff. Case management and social workers, again, they connect them to those outreach programs or support groups that they may need. Housing situations, they may navigate financial burdens that they may have. Whereas the UAP or mental health workers can do those 15-minute roundings or the one-on-one observations and help perform ADLs. So let's us review. I have some practice questions here. Which assessment finding most clearly indicates that the patient may be experiencing a mental illness? And without going through all of them, it is when they report that they are sad, discouraged, or a hopeless mood. Because remember, that can be prodromal for depression or maybe for suicidal ideations. Which assessment finding most clearly indicates that a patient may be experiencing a mental illness? The patient reports feeling consistently sad. I just copied and pasted twice, yo. Wrapping up, the last things I wanted to talk about were just about the key points and some things that were not mentioned in the PowerPoint or the lectures, but something that we do have to know that carries on for professional nursing. So the first being ethical principles. So don't forget beneficence, justice, autonomy, fidelity, and veracity. So this is something that we employ no matter what, across anything. So beneficence is the ability to do good, to do good for people. Justice is essentially fair and equal. So you are not going to, favor one patient over the other in counter transference. Autonomy is promoting independence. Okay, fidelity is trust. So if you tell them that you're going to meet them at a certain time, you better meet them at that time because that promotes fidelity. And veracity is honesty. Next, we have tort. So tort is just a broad umbrella term. So tort is a wrongful act or infringement of a right that may lead to civil liability. And the two that we talked about is negligence and malpractice. So what's the difference between negligence and malpractice? Well, negligence is, and I'll read it here, failure to exercise the care that a reasonably prudent person would exercise in like circumstances. So negligence would mean that they were harming them by carelessness, but not intentional harm. And that's the difference between malpractice. Malpractice is when they fail to provide adequate services per the standards set by a governing body like the BRN or whatever. So that's something important to remember. Elopement is when the patient just runs against, they just leave. They go AWOL against medical advice. And don't forget our levels of prevention as well. So we have primary, secondary, and tertiary levels of prevention. Primary is going to be like educating before it happens, right? Secondary is like management of something, screening of something, okay? And then tertiary is, again, rehabilitative. So they already gone through the brunt of everything. So we're restoring back basic functions like OT and PT and such. And I think that is it. So let me just briefly actually go over the answers now, and I'll also discuss, tying into everything that we learned so that we can wrap everything up. So let's go over the practice questions that we have. So a nurse performed these actions while caring for a patient in inpatient psychiatric setting. Which action violated patient's rights? So prohibit a patient from using telephone, patient's presence, open a package, okay, remain. So prohibiting a patient from using the telephone, because remember, in an inpatient psychiatric setting, they have all of the rights except the right to leave. Remember, you still have to give them the right to visitors. You still have to let them color or draw or whatever, okay? So the next one that we can talk about is a psychiatric nurse discusses the rules of therapeutic milieu and patient's rights with a newly admitted patient. Which rights should be included? So, therapeutic milieu and patient's rights. So, the right to have visitors, confidentiality, and complain about inadequate care. So, this one's very important because remember, they don't have a private room. That's seclusion. We cannot give them seclusion without an order, and they cannot select the nurse assigned to their care. Okay. A nurse prepares to administer a scheduled injection of haloperidol to a patient with schizophrenia. As the nurse swaps the site, they say, stop. What should you do? Well, you definitely want to make sure to stop it because that is their, right. However, you want to explore what they mean. So tell me more about the side effects that you've been having. Not only does this respect the patient's rights, but you're also performing an assessment to just understand what's going on in their mind, and that's very important to remember. An adolescent hospitalized after a violent physical outburst tells the nurse, I'm going to kill my father, but you can't tell anyone. The nurse's best response is to, obviously, you have to warn and you have to share that information because remember, this is the duty to warn. Okay, if they are threatening to harm someone, it's duty to warn. So you definitely have to share that information with the treatment team. But also, these are the people that are directly involved as well. A voluntarily hospitalized patient tells the nurse, get me the forms for discharge. I want to leave now. Select the nurse's best response. So you definitely want to this one. I will get them for you, but let's talk about your decision to leave treatment. Because the thing is, even though this one is allowing you to get the consent to leave as well, this is non-therapeutic. You want to try to explore why. Because ultimately, remember, your goal is to promote them from having to come back. Okay? And how can you do that without understanding what was wrong? Because maybe you can fix it so that they don't leave. And it's also legal. You are still fulfilling your legal needs. Which individual diagnosed with a mental illness needs psychiatric hospitalization the most? An individual who gets a panic attack, visions of demons emerging from cemetery plots throughout the community, who takes 38 acetaminophen tablets after the person's stock portfolio becomes worthless, diagnosed with major depression, who stops taking prescribed antidepressant medications. So, though it may seem like all of these are pretty bad, okay, the correct answer is C. The reason why is because, aside from B, though someone may need hospitalization for B, C is the most because think about Maslow's hierarchy of needs. This is physiological and safety too. They're imminent danger. So we definitely need to treat those who are extremely suicidal first. So C is the correct answer. During which of the nurse-patient relationship can the nurse anticipate that the identified patient issues will be explored and resolved? Working phase, because we are exploring and trying to resolve them. Identify the patient's issues will be explored and resolved. It's not orientation, because orientation is setting goals, and it is goals for termination, and you're introducing yourself, you're setting boundaries. Termination, they're already resolved. You are just reinforcing it. So working phase is when you are actually exploring them, identifying those issues. 8 is a staff nurse completes orientation to a psychiatric unit. This nurse may expect an advanced nurse practitioner to perform which additional interventions. Again, this goes back to our treatment team. So they are actually going to be prescribing medication because we can't. We do the mental health assessments, and we establish therapeutic relationships, and we make the nursing care plans. Which finding best indicates that the goal demonstrates mentally healthy behavior? So this is A, sees self as capable of achieving ideals and meeting demands. So this B is not it because it says without considering consequences. That's not what we want. Aggressively meets own needs? No. Seeks help from others when assuming responsibility for major areas of own life? No. That's not even demonstrating mentally healthy behavior. It's you're capable. Resilience and stuff. A nurse uses Maslow's hierarchy of needs to plan care for a patient with mental illness. Which problem will receive priority? Refusing to eat or bathe, alienation from the family, reluctancy to participate in social activities, unaware of medication actions and side effects. Now, these are all part of the pyramid, yes, but remember the base is physiological needs and safety. So that is the refusal to eat or bathe. That's something that we need to take care of right off the bat, because that is a basic physiological function, especially eating. Inpatient hospitalization for persons with mental illness is generally reserved for patients who present a clear danger to self or others. Okay, this is our priority. If we hospitalize everyone for everything, we won't have enough space to begin with, but this one is our priority, which is why they're on a 5150, which is the danger to self, others, or gravely disabled. A nurse inspects an inpatient psychiatric unit and finds that exits are free of obstructions. No one is smoking and the janitor's closet is locked. These observations relate to coordination of care for patients, management of milieu safety, management of interpersonal climate, and use of therapeutic intervention strategies. This is management of milieu safety. Remember, safety this is their already inpatient psychiatric unit. Okay, milieu is employed to promote safety and success. Remember. So no smoking, no stimulation. We're not blocking anything, and we're preventing them from harm by locking the janitor's closet. That's a big aspect of milieu safety for an inpatient care. Not interpersonal climate, because this is not between people, and we're not coordinating the care of different patients. This is just, setting up the environment. Therapeutic intervention strategies, no. An adolescent client is admitted to an acute care unit following an attempt to commit suicide. He hasn't said a word to anyone. Which of the following interventions should the nurse plan to implement first? One-on-one observation, encouraging the client to interact with peers, teach the client about medication for depression, and obtain a medical history from the client and family. So, following attempt to commit suicide. Remember, this is so very important. Anytime you see something that has imminent danger, you definitely want to address that first, which is why you want to arrange one-to-one observations. Whilst these are good, that is not the priority setting. A nurse is told during a change of shift report that the client is stuporous. When assessing the client, which of the following findings should the nurse expect? So this one we didn't quite go over, but if they are stuporous, they are able to still respond to pain. Okay, this is in your ATI book. Which statement about diagnosis of a mental disorder is true? So, symptoms of each disorder are common among all cultures? Absolutely not. Remember, they are culturally defined. Culture may cause variations in symptoms for each clinical disorder. All mental disorders listed are seen in all other cultures, and psychiatric diagnoses are listed in separately or from other physical disorders. That one doesn't make any sense. Its cultures can cause variations in symptoms. I should have just stopped it there. A cognitive therapist would help a client restructure the thought, I am stupid too. So cognitive therapy, remember, cognitive is rethinking negative thoughts. It's all in the mind, okay? Reframing your thoughts. So instead of I am stupid, you should say what I did back then was stupid, but I am not stupid. So it would be A. The premise for underlying behavioral therapy is behavior is learned and modified. Okay, that's pretty straightforward. Remember how we talked about behavioral therapy is behaviors, changing behaviors, abnormal or maladaptive ones. Which of the following is most vital element to therapeutic milieu? Again, success and safety, A. Not rest and recuperation. We're not wanting them to go to sleep. We want them to be calm and safe. And then staff to manage, of course not. That's not it either. A client is admitted for the third time to a psychiatric hospital with diagnosis of schizophrenia. During the admission procedure, the nurse notices that the client is limping, dirty, and unkempt, and appears to be hallucinating. Which of the following is the nurse's priority assessment? So, Is it the perception of reality, the support systems, physical needs, or mental status needs? Again, Maslow's hierarchy of needs says physical needs because dirty and unkempt. That's something that we don't even want for ourselves. So we definitely need to report that first because that's physical. It's the body, okay? Do that first. Which of the following documents the client's affect? Remember, affect is what they express. So obviously, crying, frowning, and blunting. Worthlessness and being happy is inside. And with that being said, I hope that helped.